guys a little bit about what is the data on fertility and testosterone and what actually causes the infertility, and then how can we treat it, what can we do to minimize it. And then I'm going to talk about low testosterone and what are the treatments for this and what are the risks of this. I'm going to go over, just like if you were my patient in the office with me and I'm talking to you, this is how we're going to work through it today. So the good news is that cancer survival rates in the U.S. are increasing. But the bad news is that there's a rising incidence of all cancer diagnoses in those younger than 65 years of age. And 9% of cancer diagnoses in the U.S. are in patients less than 45 years old. And 1% are actually in patients less than 20 years old. While the overall survival of childhood cancers is over 80%, which is fantastic, 400,000 children worldwide are diagnosed with cancer each year. So the majority of patients in these age groups are living beyond their cancer diagnosis and treatment. So that's a huge need to talk about fertility preservation and quality of life from a sexual and reproductive standpoint. Even testicular cancers, which primarily occur during that peak age of reproduction or close to it. Approximately 250,000 testicular cancer survivors currently live in the U.S., and that's increasing and growing. And due to improvements in treatments, again, most patients are going to outlive their cancer diagnosis and treatment and live a long life after diagnosis. However, we're leaving these patients with major lifelong quality of life side effects. And one of the major long-term side effects of cancer treatments is infertility. And this could be due to the cancer itself or the treatment options such as chemo or radiation therapy, which have detrimental effects on the testicles. Data actually shows that males are more than 2 times more likely to suffer infertility than females that have cancer diagnoses, and that males and females with cancer have lower rates of fertility than their sibling controls. Sexual dysfunction is a huge problem, and it's under-asked about, it's under-talked about. No one wants to bring it up because it's forbidden. We're not supposed to talk about sex, but it's so natural. I mean, it's indicative of the survival of our species, right? Like, we know everyone's doing it because all you are in a room today, so somebody did it. So again, it's something so important, right? So as I mentioned, it's not just the treatment of cancer that can cause cancer, but also the cancer itself, such as in testicular tumors. Beta-HCG and alpha-fetoprotein, they decrease hormone production, and they actually decrease sperm production in the testicle. Prolactin, patients that get tumors in the brain and prolactinomas, they also can lower hormone levels and cause infertility. The direct tumor invasion of the structure, right, in the testicle itself, it's impacting the tissue, the cells that produce sperm, the cells that produce testosterone, so we can see impacts of that even before patients even may know that they have a testicular cancer. Fevers and looking at temperature regulation. Our testicles hang outside the body because they need to be 2 to 4 degrees cooler than the rest of the temperature of the body. And that's to do the 2 main things they do, which is make sperm and make testosterone. So if you have fevers, you can actually get testicular or sperm dysfunction that can last up to 3 months after one. Again, all of these things can occur just from having cancer or a disease process going on in the body. So again, the testicles do 2 really important functions I'm going to talk about today. They make sperm and they make testosterone, but we're going to focus on making sperm right now. So this is just a fun diagram. Maybe you remember when you were in like biology class or something, science class, but this is what's happening in your testicles every day. And while men make sperm every day, unlike women that are born with all of our eggs, the sperm you make takes about 90 days to go from a baby sperm to a mature sperm that can fertilize an egg. And so it's those baby sperm actually that you see, and these are the ones that are going to be most sensitive to any injury or the cancer itself. And so any impact actually takes about 30 to 90 days before you can see the impact when it starts, and then it's going to last that long even after the insult, if not longer. So as a result, even before treatment, men with cancer have impaired sperm production. So in the general population, we have something called non-obstructive azoospermia. That just means that in the ejaculate we see no sperm at all, and that's prevalent in about 1% of the population. And this study looking at childhood and adolescent cancers out of Pennsylvania, 17% of cancer patients were azoospermic at presentation, and then 84% after their treatments. Here, when we look at testicular cancer specifically, we see men with testicular cancer have lower sperm quality compared to those with other malignancies, even at baseline. And that's not too hard to reach or think, right? Because it's occurring in the testicle, where the main process of sperm production and hormones are taking place. But oligospermia, another big fancy word, just means low sperm counts and low motility. But also we see that oligospermia is prevalent and seen in over 50% of testis cancer patients prior to treatment. So now add in chemo, add in radiation. So this is just a fun little diagram of all the different treatments that we give to cure cancer. And the problem is they do this great job of curing cancer, but they can have some pretty harmful effects on sperm production. These are just all the different mechanisms of action of how different anti-cancer agents work in the body. And we know that different chemotherapeutic agents or regimens, they can affect sperm differently, as seen here in just this study of sperm recovery rates. You see it start, it goes a dip, and it comes back up. But not every sperm recovery comes up the same. And also, everyone's different at baseline. Some men have poor sperm parameters at baseline, or their sperm may be more sensitive to any toxic injury or treatment options. There's also a dose-dependent effect, right, on sperm parameters, with higher doses impacting sperm greater, as this graph shows increasing doses of cyclophosphamide, another common chemotherapeutic agent, showing greater impairments in sperm production. In a review of patients who received BEP for testicular cancer, you can see that in those that received less than 2 cycles, sperm production returned. Sperm production, if it returned, took closer to 24 months after treatment. So again, you see this dose response in everything. Now these are just some commonly used chemotherapeutic agents. And you'll see that alkylating agents and your platinum-based agents, they're going to have the highest risks of infertility, though all of them are going to impact fertility to some degree. Here again, just more chemotherapeutic agents, but these are specific ones that are only used in testicular cancer. And I just highlighted some of the more common ones, but you see many of these have a high or intermediate risk of irreversible infertility when we're given these. Looking at just a single cycle of sperm recovery after cisplatin-based chemo, you see that 48% of patients can recover spermatogenesis in about 2 years, but it takes about 5 years before 80% of patients will have some recovery. And that doesn't mean that it's back to normal or baseline. It just means that you're starting to see some sperm return to the ejaculate. Radiation therapy, even despite testis shielding that we do, can also injure the testicle, and it can decrease spermatogenesis as well as create hypogonadism or low testosterone. So let's just pause. I gave a lot of data, a lot of information, but let's see. Although there's these regimens and dependent dosing that vary on gonadotoxic risk, let me just point out that there is absolutely no risk regimen. I'm sorry for the double negative, but there's no regimen that we can give anyone that isn't going to have any risk, and we can't always predict what that risk is going to be. So even if something's mild or intermediate, maybe in one particular patient, it's going to be more of a high risk in that one because we don't know how to predict these things yet. So even surgery, right, we just talked about treatment, but even surgery can impact fertility. And you say, well, how's that? Well, even semen parameters or sperm parameters, which is where we look at sperm counts, how fast they swim, their motility, and their shape, are impaired after orchiectomies. In fact, studies have shown that semen quality is actually worse before you have removal of the testicle, and then it can even decrease post-orchiectomy compared with your pre-treatment levels. And even having that normal remaining testicle, semen parameters are impaired in about 85% of patients after an orchiectomy. So think about it, you've lost 50% of your machinery that used to make sperm and used to make testosterone. And so the old adage that we used to be taught, or at least I was taught in medical school, that one testicle can do the job, we're seeing that that actually isn't true. And over 85% of patients have abnormal sperm parameters after an orchiectomy. An additional 9% for various reasons will go on to develop azoospermia, or no sperm at all that's going to be seen in their ejaculate. Now, the American Society of Reproductive Medicine, or the ASRM, this is why they put out a new recommendation saying that we should be banking sperm before orchiectomies, because maybe this will be our best shot at having the healthiest, best sperm parameters. But let me just remind you that there's no time that is too late. We will take sperm banking and procedures that I'll talk about today, even after someone's had a history of chemotherapy, because many times we can still find sperm. So surgery impacts fertility even with your retroperitoneal lymph node dissections. Men are at risk for what's called anejaculation, or no ejaculation that comes out, or retrograde ejaculation, which is where instead of the ejaculate going forward or antegrade out through the penis, it goes through the path of least resistance. So it goes backwards, and it actually goes into your bladder. Now, not a big problem for someone who's not interested in fertility. You'll just void it out the next time you go to the bathroom. But in a young guy who's interested in fertility, we don't want it going backwards. We want it going forwards. So most of the time, this is just due to disruption of the sympathetic nerves, or how the surgery occurred. Luckily, we have excellent surgeons, Dr. Carey and Dr. Masterson here, and so less than 10% of patients now suffer from this if they've had a nerve-sparing RPLND. So you hear these diagnoses, you hear these words, you have cancer, right? And we've all shared today, and we've been so open, that when you hear these words, it takes you a step back, right? All of a sudden, everything that you've thought was going to happen in your life, it's all of a sudden at a standstill, right? And I think this picture just kind of really shows, like, all of a sudden these plans you've laid out and everything that you're thinking about what you want to do for your future, it's changed, and you don't know if any of this is going to happen. And so fertility preservation and talking to patients about this and bringing it up is us banking on the future. It's us banking on the hope that we see you on the other side of this, and we know that you're gonna make that, and then we're gonna have this option to help you be a daddy, or to help you build your family in the way that you see fit. And the good news is that successful paternity has been achieved in testicular cancer patients, independent of the treatment that they received, or if they cryopreserved before their treatment, whether that's radiation therapy, chemotherapy, doesn't matter. And in fact, looking at almost 700 testicular cancer patients, where they had an orchiectomy, some had surveillance, some had chemotherapy, and radiation therapy. Paternity was achieved naturally in over 77% of men. And then with the use of new assisted reproductive techniques, which means either IVF or in vitro fertilization, or something else called IUI, or intrauterine insemination. Using the help of assisted technologies, an additional 23% were able to have father paternity. So overall, the success rate is very high, regardless of what treatments people have, and it can range anywhere from 85 to 67%. And this is really due to a lot of pioneering work back in 2006, when the American Society of Clinical Oncology, or ASCO, made their guidelines that basically they called for clinicians to discuss at the earliest possibility after diagnosis the risk of fertility impairment and the prompt referral to a qualified specialist if the patient is interested. Despite this coming out in 2006 and then getting revised in 2013 and then again in 2018, we still have over 50% of institutions in the United States that don't have a fertility preservation program, and they don't bring up fertility preservation when patients are diagnosed with cancer. And so we're working hard to build that, to change that, to break the barriers that are the results of that. So what options do we have for cancer patients and preserving fertility and testicular cancer patients specifically? We have 4 mainstays. One is going to be your sperm banking or regular cryopreservation. We have electroejaculation. We have something called a TESE, or a testicular sperm extraction, oftentimes just called a testis biopsy, or when done at the same time as an orchiectomy, it's an onco-TESE. And then we have what's called a Micro-TESE. Now I'm going to go into a little bit about all of these, but why do we even bring up sperm banking? Well, ejaculated sperm is relatively safe. It's non-invasive. From what I hear, it can actually be pleasurable to do. And even pre-treatment abnormalities can be used for assisted reproductive technologies. So even if your sperm is abnormal, it doesn't matter, because with assisted reproductive techniques, you only need 1 sperm and 1 egg. Sperm can be frozen for decades, and paternity rates are actually similar to natural conception. And even after banking, only about 16% of patients end up discarding their sample. So it's something they want to do, and what they find a lot of pleasure in doing, and even if they don't use it, they're glad that they did it. Now, there's a couple barriers and considerations. Can the patient ejaculate, right? Are they able to? Sometimes with the anxiety, the stress, the pain that they may be experiencing, you're not able to relax and do this. Sometimes they need help with some medications like Viagra or Cialis. There may also be religious or cultural reasons where patients are not allowed to manually stimulate to procure a specimen. Also, many of these happen to young patients, right, under 18. Maybe the patient and their family haven't even thought of parenthood. Some kids do. My little 7-year-old tells me one day that he wants to be a daddy one day, but he's only going to have one because he doesn't want him to have to share his toys like he has to do with his brother. So I'm like, pretty smart. But a lot of kids have never thought about this, right? And all of a sudden they're given a cancer diagnosis, and now you're talking to them about, do you want to be a daddy one day? This is what we're going to do, and we're going to do another procedure in the OR for you, or whatnot. Also, there's some long-term costs. You know, this isn't free, unfortunately. I wish it was, but the process of cryopreservation and assisted reproductive technologies can be very expensive. IVF here, for example, in Indiana is anywhere from $25,000 to $30,000 for a round of IVF. So it's extremely expensive. And then there's ethical considerations. Well, not the highlight of this talk, but we also have a pre-pubertal fertility preservation program here that we started. And so when you're talking about under puberty, patients that haven't even reached puberty yet, and you're talking about it, it can be a little experimental because we don't have any data yet. We don't know for sure if it's going to work. We hope it is, and that's what the research shows, but we're not there yet in an actual human being to use those tissues yet. So, a lot of things. Now, this is a great guideline that came out from Northwestern where they put together to give all of the physicians like me a really nice guideline of how can you treat patients when they come in with a new diagnosis of cancer. And obviously here for the post-pubertal, we're going to talk about sperm banking and go through the other options that I mentioned with you. So manual sperm collection. This is the easiest, quickest, most efficient. It can be either done in a lab or an IVF center. They manually collect a specimen. You want to wait about 2 to 3 days and not longer. And the reason for that is that when you make sperm, you know, it takes that 90 days to go from a baby sperm to a mature sperm, but sperm only live 24 hours to 5 days. So if you're at 4 or 5 days, half your sperm has already died. So if you go get a semen analysis, it's going to show me some abnormalities. Either the motility is going to be abnormal or your counts are going to be abnormal. And that may not actually reflect what's happening. It may have just been you waited too long. You want to make sure you get it all in the cup. Sounds kind of silly, but sometimes it's really hard to do. You're focusing on this. You have so many other things in your mind, and you don't want to spill it. You don't want to miss it. You want to make sure you catch everything, right? And you can't use any lubrication because it slows the motility of the sperm. Also, again, not as expensive as IVF, but it's still not cheap, and it's usually not covered by insurance. It's about $150 to $200 for the processing, and if there's sperm there, you're going to end up paying anywhere from $200 to $350 for each year of storage thereafter. Now, you also have to be post-pubertal. So again, if someone is in that peri-pubertal stage, right, maybe they haven't hit puberty, they've just started, you know, maybe they can't do this just yet, and so at least the other options that I'll bring up. Another great option that I do refer a lot of my patients is the Meet Fellow. This is an option online, as long as the patient has at least 48 to 72 hours before they need to start chemotherapy. You go online, you use your credit card, you order the kit, it gets shipped to your house. You have everything perfectly labeled out for you to manually procure a specimen in your own privacy of your home. You overnight ship it the same night, and then within 24 to 48 hours, you get the results back. Now, the difference with this, though, is you may not get the results back to show you whether you have sperm there or not before you have to start chemo. So it's an excellent option, but if someone is in a crunch that's about to have to start chemotherapy very quickly, this may not be the best option, and they may need to go to an in-person lab here so that if we don't find sperm, we can try to do something else before they start chemotherapy. So electroejaculation, it sounds scary, but it's been in use for over 80 years because we used to use it in farm animals for reproduction. So what is electroejaculation? Well, it's actually used for patients that have an inability to ejaculate, whether that's due to neurological disorders, prior surgeries like an RPL&D, medications, pain, anxiety, or even that peripubertal patient that's kind of in between, just started puberty. What happens is patients are brought to the operating room, so they're placed in the rectum, and it's pressed up against the anterior prostate and the seminal vesicles. And you deliver 1 second small shocks that stimulate the nerves to produce ejaculation. There's no opening, there's no cuts, there's no incision that has to heal. It's done in about 10 to 15 minutes, but it does require them to undergo an operating room procedure where anesthesia is given. It's very successful, and it's something that works really well even in patients that have that retrograde ejaculation or issues with ejaculation due to diabetes or other conditions. So the next step, if you can't do that or you don't have sperm in the ejaculate, we have something called a TESE, or your testicular sperm extraction, or testis biopsy. This is a straightforward procedure that can be either done as a local anesthetic in the clinic with me, or it can be done in the operating room if someone's undergoing another procedure like a port placement or a bone marrow biopsy. It's very quick, it's very efficient, you're done in about 15 minutes. There's never been a delay in chemotherapy in all the years that I've done fertility preservation here and at Memorial Sloan Kettering during my fellowship. So everyone has been able to start chemo right away, some including the same day we did this procedure, and there was no infections. And to give you an example of just how quickly you can put this together and how, no one is without that window of it being too late. 2 weekends ago, I was at this little event Friday night, and I get a phone call from our amazing PET fertility preservation director. She calls me, she's like, we have a patient tomorrow. Can you do him tomorrow? And this is Saturday. And I'm like, I'd love to, but I don't have a babysitter. Her husband was out of town. I was like, I don't have a babysitter until around 3 o'clock. Can we do it that late? And unfortunately, the IVF lab was going to be closed. They couldn't do it. And I'm like, what are we going to do? I used my whole Rolodex. I called 5 people. I could not find a babysitter to come to my house early. So the wonderful PT monk attending came over to my house Saturday morning, and she babysat my kids so that I could go to the hospital and do this testicular tissue preservation on a patient that had testicular cancer, and I had permission to talk about him today. And he had shown up at a very advanced, had a huge mediastinal mass, and had to be intubated. So this patient couldn't do a manual procurement for me, right? And he had actually already gotten 1 dose of cisplatin to try to help calm things down. And his mom actually works for a urologist. And she didn't know about fertility preservation. She didn't even know it was an option. She happened to be on the phone with someone when the first round of chemo got hung from one of her friends that said, are you going to save the sperm of your son? And she was like, I didn't even know I could do that. So at 6 o'clock on Friday night, the PT monk attending went to go see this patient, consented the family, discussed it with him. She shows up at my house Saturday morning at 8. I roll over into the Riley. We did a testis tissue biopsy, and you know what? We preserved 4 vials, and he had tons of sperm. So this kid's going to be able to have kids one day if he wants to. So it's so rewarding, and it's so exciting, and all of us that do this feel like this is a calling. It's not just a job, and it's so special. So again, these things can be arranged very quickly if need be, and they work even in patients that are in advanced stages, even in patients that have already had rounds of chemo. What about the patients that don't get that? The patients that are in an institution where no one brings up fertility preservation, and they've already undergone chemo, they've already undergone surgery, radiation maybe, and now they're in their late 20s or 30s, and they have their partner, and they want to have kids one day. And they do a semen analysis, and they don't have any sperm in it. We still have options for that. This is called a micro-dissection testicular sperm extraction, or what's called a Micro-TESE. And this is also an operating room procedure that's typically performed at the same time as when they're about to undergo what's called IVF, or in vitro fertilization, where the female, you're going to harvest eggs from her from an IVF lab, we'll take sperm from the patient, and it's put together in the same day. This is, again, a same-day outpatient procedure, usually done in a surgery center. Patients are asleep, so they don't feel or remember anything. And using an operating microscope, which magnifies things 40 to 100 times, we make an incision in the testicle, and under this microscope, we look for any dilated tubules that we might see. Because the truth is that while chemotherapy or radiation or even surgeries itself injure the testicular tubules, it usually doesn't injure 100% of the testicle. There's tiny little areas of the testicle what's called patchy spermatogenesis, which is where tiny little areas that sperm is actually growing and developing. And so under this microscope, we can see round tubules that allow us to pick out that one tubule in the top right-hand corner that might have sperm, and all you need is 1 sperm, and that can be used for IVF and help patients have kids. And I have done several post-chemo RPL&D patients where we have done this procedure, and they've been successful. Success rates for this are anywhere from 40 to 60% depending on the patient. So this surgery is not too old either, how long ago it was developed. So now up to 60% of patients that previously never had an option can now look at having parenthood and being a dad again. So super exciting, and there's still a lot of experimental things upcoming for the prepubertal kids, and so many things I want to talk about, but I don't have time on this lecture. So this is just this is Amanda, the amazing PT monk attending who started the fertility preservation program with me in 2019 when I started. She is fantastic, and we have some amazing nurse navigators, Lisa Sutton and EJ Whitaker, who are here at Riley, who scan the peds and adult hem-onc lists. They look for patients that are undergoing chemotherapy or radiation, and they approach all of these patients and offer fertility preservation. And it really could not do this without the team that we have. We have such an amazing team of nurses, pediatric and adult urologists who all help me when I'm not available to do it. so that we can offer this here. And this is just a quick showing of just from 2019 to 2022, how many male fertility preservation cases we have. And this is just really exciting because before 2019, these patients had to be sent to Cincinnati or to CHOP. Otherwise, there weren't any options for fertility preservation here. All right, so again, there's two functions of our testicle, right? We have sperm and we have testosterone. So let's talk about testosterone. Well, low testosterone is common in testicular cancer patients for many of the reasons I just talked about. The cancer is in the testicle oftentimes, so it's the disease process itself that's injuring the tissue that's making testosterone or sperm. Also the treatments, right? The orchiectomy can impact it because you're losing half of your machinery that makes testosterone. Orchiectomy, chemo, radiation, all of these things can impact testosterone production. Looking at Dr. Einhorn's study of the prevalence of hypogonadism after just cisplatin chemo, more than a third of testicular cancer thrivers are still having hypogonadism. And in addition, these patients had increased risks of cardiovascular disease risk factors like hypertension, high blood pressure, high cholesterol, and erectile dysfunction. So obviously, all providers should be screening testicular cancer thrivers for hypogonadism and treating symptomatic patients. But again, it still doesn't happen all the time. And unfortunately, testosterone levels after chemo don't always rebound. We know that about 25% of patients will always stay hypogonadal. We know that another 50% will never come back up to what their baseline was before they started treatment. And only less than 25 actually get back up to where they were. So only 1 in 4 actually goes up to where they were before treatment. So how do you know if you have low testosterone, or how should you be checked for this? Well, what are signs and symptoms? Dr. Einhorn gave us a nice example yesterday, but there's physical symptoms, there's cognitive symptoms, there's sexual symptoms. These guys come in and they feel tired, they feel fatigued, they feel awful. They've gained some weight, they've lost lean muscle mass. They go, you know what, I kind of feel foggy, I have a really hard time remembering things. I just can't really concentrate like I used to. And maybe it's just old age, maybe it's just as I'm getting older. Or sexual symptoms, which is typically the most common things that will bring younger guys in to see me, is that, hey, I just don't have that libido, I'm not interested at all, I could care less, or I'm not getting the same erectile function, I'm not able to maintain it the same way. So all of these things can be presenting symptoms of low testosterone, but it's multifactorial and it's non-specific, right? Because depression, a lot of things can contribute to symptoms like this. So what is low T then, and how do you diagnose it? How do you know it's related to low testosterone? Let's go back to the guidelines, because I'm a big guideline follower. So the guidelines for the American Urological Association, or our AUA guidelines, say that we need a total testosterone level under 300, and that it should be drawn after 2 different early morning values, okay? And the reason for that is that testosterone is diurnal, so it's going to be highest in the morning, and it slowly declines throughout the day. And it actually drops about 30% within the first hour of you waking. And that makes sense, right? We want to be alert and motivated and have energy in the morning. And by nighttime, we want to be able to be a little more sleepy and tired so that we can rest and recover. And then it also can be only made when you have 2 things: low testosterone, so under 300, and you have signs or symptoms, which we just talked about. So what's the big deal about T? How does this really impact men's health? If it's just about erections, or maybe I have couples that say, well, we're not really sexually active, so why does it really matter? Well, because it's not just about libido, it's not just about energy, and it's not just about sex. Patients with low testosterone levels are much more likely to develop bone fractures or osteoporosis or osteopenia, type 2 diabetes, metabolic syndrome, which is the conglomeration of body mass index, obesity, high blood pressure, high sugars, high cholesterol, as well as cardiovascular events, heart attacks, and strokes. This was a study from the VA, and they just looked at aging males and mortality rates. And they just looked at all male veterans at the VA who were greater than 40 years old, and they followed them over 5 to 10 years and just looked at their testosterone levels and their comorbidities. And after adjusting for everything, looking at age, looking at what other comorbidities they had, any baseline, high blood pressure, they found that low testosterone levels alone continued to be associated with increased mortality. Let me say that again. Just having low testosterone increases your mortality, your death rates. So how common is it? Is this something we need to worry about? Well, we know it's common in testicular cancer patients. Let's look at these 3 big studies. These are kind of the most popular studies in the urological world. The European Male Aging Study. This was over 3,000 patients from ages 40 to 79, and they found about 14% of guys had hypogonadism, and they used a cutoff of 300. Then we have the hypogonadism in males study, or the HIM study. This showed that the overall prevalence was almost 40% of hypogonadism in all guys 45 years or older. And then our famous Massachusetts male aging study, which gave us all this great information to let us know how common erectile dysfunction is, it also showed that there was a symptomatic prevalence of low testosterone that increases about 5% with each decade of life. Low testosterone is also more prevalent in other patients with certain chronic conditions, not just cancers, but patients that have high BMI, the central obesity, that tummy weight, people that have a history of chronic opioid use, the chronic narcotic use, patients that have diabetes, even AIDS, HIV/AIDS lowers testosterone levels, hyperlipidemia, and of course erectile dysfunction. So this is common, and these are people walking around every day with many of these conditions. So a couple thoughts when you think about it, then the medical conditions and their effects. Well, testosterone deficiency can lead to all of these things: cardiovascular disease, diabetes, metabolic syndrome, but also all these things can lead to testosterone deficiency. So they're interrelated. You need to have healthy testosterone levels to prevent this, and it actually helps control these symptoms. So let me show you. This was 3 different studies where they looked at men with diabetes, right? Diabetes is so common and prevalent, over 15 million Americans living with diabetes right now. And they gave these patients just 3 months of testosterone supplementation. We didn't change their diet, we didn't change exercise, we just gave them testosterone. And we showed that in 3 months they had lower fasting sugar levels, their mean daily sugar was slower, and their hemoglobin A1C, which is a blood marker we look at that tells our 3-month value of your sugar levels in your body, was lower just by treating their testosterone, nothing else. They found that long-term testosterone therapy improved their insulin sensitivity and reduced body fat. Again, I'm not talking about dieting or changing their exercise, just giving people testosterone. And that people that were on testosterone therapy actually had their insulin medication dosage reduced by up to 7 units. That's huge. I don't know any other medication that can reduce diabetes medications like this, just giving someone testosterone. What about cardiovascular disease? That's one of the #1 killers of men in the United States. Chronic testosterone actually reduces arterial calcification. It improves your lipid profiles, which is your cholesterol, triglycerides, and it increased cardiac output in men with chronic heart failure. They found that the average distance walked by men given testosterone therapy was 91 meters versus 26 in guys that just got a placebo, which is like a sugar pill. They didn't even know what they're getting. Well, let's look at a few more, right? Maybe these are just a few random studies. Maybe it's not real. 52-week treatment with diet and exercise plus testosterone reversed metabolic syndrome and improved men with diabetes. So they took 32 guys that had metabolic syndrome. Again, that's obesity, high blood pressure, high blood sugar, and triglyceride cholesterol. And they did some with just exercise, some with exercise and testosterone. And the ones that they added testosterone to, they found 81% of these guys no longer had metabolic syndrome. They didn't even meet the criteria. They didn't have these conditions anymore, versus only 31% that just did the diet and exercise alone. So when I have patients come see me, or they tell me they went to see someone else who said, no, you need to work on diet and exercise first before I'll give you testosterone. I say, no, give them testosterone and they're going to feel better. That weight's going to drop off. Their sugars are going to be better under control. They're going to have more energy, and then you're going to see those lifestyle modifications really take off. There's no need to wait. And this is the study that'll tell you why. So body weight loss reverts obesity-associated low testosterone. So they did this long study called systematic review and meta-analysis. That just means you go online and you pick up all the studies on a given topic and you analyze them all together to create one result based on all of the results together. And they looked at 24 articles that all looked at weight loss and hypogonadism. And they found that obviously the guys that underwent surgery had a little bit better weight loss, right? 32% with bariatric surgery than just less than 10 if you just tried to do diet alone. But bariatric surgery increased testosterone levels about 252 points from their baseline, versus doing a low-calorie diet and exercise, really you only got about 83. So think of, I try to encourage when I do my lectures to like primary care doctors and endocrine doctors, when I show them this, that when you're telling someone, go lose weight and go exercise, at best you're going to get them up 80, maybe 100 points from where they are. So if they're already low at like 200, you're still barely getting them to 300, which is still low testosterone. So again, this is so important, and it dramatically improves patients' overall quality of life. This isn't just about erections, this isn't just about sex, this is about your overall quality of life, about things that can really impact your health. So who should we treat, and what are the indications for treatment? Well, We just talked about guidelines say you gotta have a testosterone less than 300 and you need to have signs and symptoms. But I'd also argue that you should consider measuring testosterone in these populations as well. And here, what do we see some commonalities? Exposure to chemo, exposure to testicular radiation, male infertility, a history of cancer, or any chronic steroid use, right? Even in the absence of symptoms or signs, these patients have association with low testosterone levels. So by not checking this in your patients, you're really doing them a disservice when I talk to my physician partners and colleagues, because you're not diagnosing low T that can predispose them to all these other comorbidities in their life. All right, so you have these symptoms, right? And you have risk factors for low testosterone. And now what? Well, what are the rules of engagement that you need to know to get started? First and foremost, we need to have realistic expectations, okay? While we can dramatically improve patients' quality of life, I have to remind myself that I am not a miracle worker, and there are some things that I just can't do. So we have to set expectations first, because we want to set you up for success. We want patients to feel good and to feel better on this medication. So what can testosterone actually do? Well, we know that data shows it can improve erectile function, it can improve your sex drive, it can improve anemia, bone mineral density, your lean body mass and muscle mass, and it can make depressive symptoms better. People feel better when they're on testosterone. But data is still a little bit inconclusive, a little wishy-washy if you look at whether it really improves cognitive function or energy levels or lipid profiles. But many of the patients report improvement, and as I just showed, there's a lot of studies that do show that improvement. So how do we get started? First, you need to get your baseline labs. Again, these are drawn 2 labs that you need to have at least early in the morning before 11 a.m. Because again, labs are highest in the morning and we want to know what's your best level. Because if that's already low, I know it just plummets throughout the rest of the day. After that, these should be fasting because I'm always going to get a lipid panel too. I cannot tell you how many young guys that come to see me for infertility or low testosterone already have undiagnosed triglycerides in the 350s. They already have high blood sugar because they're not going to see a doctor, right? This is just silent killers and they're low testosterone. So what you're going to do, you're going to get your labs, and I get a lot of labs. I get a lot of labs because I'm a sexual and reproductive medicine expert, and having all these labs is going to help me see what's the best testosterone therapy to start someone on. But at a baseline, someone can get a testosterone free and a total. They can get an estradiol level because we want to make sure that doesn't get too high, which can cause gynecomastia or man boobs. And we want to check a hemoglobin hematocrit because we don't want that to get too high. Again, that can risk clots. And we want to check a PSA in men that are 40 years of age or older or have risk factors or family history of prostate cancer. All right, so I tell them we're going to get all these labs. Then they get the labs for me, or even maybe in the same office visit, I'm going to talk to them about, well, what are the different types of testosterone we have? And they'll say, Doc, you know, I went to the store the other day and I bought this Testro X I've been taking, or this Fountain of Youth formation that I got at the Quick Mart. You know, and again, I just have to stress, you know, please don't get these. These are black market treatments. They're not regulated. They're not monitored. We don't know what's actually in them. And the truth is that most of them have some testosterone or some derivative of testosterone in them. So if you're a young guy that's looking for fertility, you could actually be hurting your fertility. And I'm going to talk about that in a minute. These are just a picture example of some of the prescription testosterone therapy options that we do have on the market. That includes nasal gels, that includes transdermal gels on your arm, pellets, or intra-injectional treatments, okay? But the important thing is please go see a real doctor, a urologist, or a primary care doctor, or an endocrinologist to get your testosterone prescription. All right, so what are the types? Well, one of the newer ones is these oral agents called Jatenzo. It's an oral pill you take once a day. I don't prescribe it a whole lot because insurance hasn't picked it up much and it's pretty expensive. But the friends that I do know that are on it, they enjoy it, they like it. It has a high risk of high blood pressure and elevated lipids. There's transdermal agents. These are your gels or your patches that you're going to put on. These have to be applied daily, and they have to be applied roughly at the same time. You want to apply it on a dry surface area, either your bicep, your chest, or your back, and you want to wait 10 to 15 minutes after you apply it before you get dressed. If you don't do that, the risk of these is transference. It can actually absorb in your shirt, and next to your female partners or young kids or grandkids, you can transfer that testosterone and mess up their hormonal axis. So it's a really big deal. And in young kids, sometimes those androgenic effects or giving testosterone to a young little girl can be irreversible, and it can cause some pretty crazy, devastating things. So You have to be someone that's really religious about putting it on right, letting it dry before you get dressed, and then washing your hands. So again, I talk about this with my patients because if you're someone that's rushing out of the door every morning, you're probably not going to spend the time to take this on and put it on correctly and appropriately. So what about your transnasal? This is kind of one of the newer ones. It's a gel that you put, like Afrin, you put a gel in your nose, both nares, twice a day. Burns a little bit, stings a little bit, but what it does is it creates this kind of variability of you get a little peak your first time you put it on, and then it goes down throughout the day, and then you get a second peak. Because of this, it's kind of been touted as one of the medications that can maybe be an actual testosterone that doesn't impact fertility as well. Again, not covered great, and it doesn't preserve fertility in all guys, so you have to be careful. Intramuscular agents, these are probably the most common for my practice, I'd say, of the exogenous testosterone. Testosterone cypionate or nanthianate, there's tons of different ones, but typically it's an injection that you're going to do once a week, either into your thigh, your buttocks, or your abdomen, and you're going to inject testosterone. Risk specifically related to this can include you get much higher peaks, you're at a greater risk for having what's called elevated hematocrit or erythrocytosis. And then I'll talk a little bit more about some of those in the next slide, the risks and side effects. Next, you have subcutaneous pellets. These are great because you just do it once every 12 weeks and you don't have to think about it again. These are pellets, 75 milligram testosterone pellets that are put either in the upper outer quadrant of the buttocks or in the forearm. You put them in once, every 12 weeks the patient comes back and gets them. And then we get repeat labs looking at these. And then lastly, alternative testosterone therapy options. What is that? Well, these are for people that are interested in fertility. Remember, our testicles do two things. They make sperm and they make testosterone. And our body is so smart, right? It always wants everything to be in this homeostasis, this perfect working order. So if you're taking outside testosterone, the body says, oh, I'm making enough testosterone. I don't need to make more. So it shuts down production of testosterone in your testicles. Well, it can't shut off one without the other. So it shuts off testosterone and it shuts off sperm. And I can't tell you how many men's health clinics see young patients and start them on testosterone and don't even talk to them about fertility. And then they come to see me and they're wondering why they're not getting pregnant, and they're still on testosterone therapy. So the good news is that we do have options that do work for this patient population, and they're called our alternative testosterone therapy options, like selective estrogen receptor modulators like Clomid or HCG or your aromatase inhibitors, which I'll also talk about in more detail. It's always important to go over risks of any medication or therapy. Again, another reason why I think it's important to go see a doctor to talk about these things, because oftentimes these men's health clinics or these, plastic surgery, facial Botox boutique places that are also trying to do testosterone, they don't really bring this up and they don't talk about it. But there's risks with everything we do and any medication we take. The risks are very specific to the type of testosterone therapy or modality that you're going to be using, such as gels with the transference, injection therapies. You can get an increased risk of POME, or pulmonary oil microembolism, which causes this kind of coughing fit that patients get in the office. You can get breast tenderness or gynecomastia, infertility if you're a young person that's wanting to keep and maintain your fertility. Testicular atrophy, that's something that bothers a lot of guys, especially some of the patients that only have one testicle. They don't want that one testicle smaller, but testosterone therapy can do that in some men, and sometimes it's irreversible, even if we try to combat it with other medications. So again, talking about all of these different impacts is really important and different risks for patients. So what's the follow-up? So we picked a testosterone therapy we want to do. You've started it. For all of my patients, they're going to get baseline labs. We start the testosterone therapy, whatever that is, and then we're going to get initiation labs after you've started it. That's 4 to 6 weeks after you've started testosterone therapy. So for example, for people that are on injections, they're going to inject once a week, and then the day before their 4th injection, I'm going to get labs. Why am I getting the day before? Because I want to know what your lowest level is so that I can titrate it to make sure that you stay within that healthy range, which per the AUA guidelines is anywhere between 450 and 650. I don't mind if they're a little higher than 650 because I'm checking other objective markers like their hematocrit and their estrogen levels and their PSA and all these other things to make sure that you keep people safe when they're on this medication. Once we get the labs back, I may titrate the testosterone therapy and we may redose it, and if so, they'll get repeat labs 4 to 6 weeks later. Once the patient is on their set testosterone, levels are in a good range, they feel good, then it's a stable dosing. So I just make sure that they understand that testosterone is a lifelong medication. You really shouldn't start it and stop it. There's no point in doing that because once you come off the medication, your testosterone just goes back down to where it was or worse. I have so many patients that come in, they're like, I took it for a few months back 7 years ago, and then I took it here. I don't know why. Again, it's just miseducation. People aren't being told correctly about testosterone therapy. But you get it lifelong, repeat labs every 6 to 12 months. In my patients that have a history of prostate cancer, I get labs more frequently every 3 months because I want to make sure that we catch any rise in PSA. And then I give people a 30-day grace period. I let them know I'm happy to prescribe your testosterone. I want you to feel good. I want you to do well. But you have to get labs when I ask you to. That's up to you and that's your responsibility. And if you don't get these labs, I'll give you a 30-day grace period. I'll refill your meds. But if you don't get the labs from me, I can't prescribe to you. And I think that that's, patients have to take the ownership and initiative of this. I'm happy to prescribe it. Many people are. But you want to make sure that you're safe too and that you feel good on it and that your labs are in a good, healthy range. So what are some special circumstances? This is kind of the last part. What about the patients that say, well, my testosterone level is 750, we started testosterone, but I don't feel anything, doc, I don't feel anything. Well, we don't know what their baseline was, right? It's possible that maybe they're hanging out in this 500 range, and before their orchiectomy, maybe they're in the 850s, 900, right? So it is very possible that someone feels a little different. Usually, more often than not, it's other causes that you have to think about. When a testosterone level is in a normal range and they still have low energy, fatigue, decreased libido, remember these symptoms are multifactorial and they're interrelated. So rule out other causes. Are they snoring at night? Do they have obstructive sleep apnea that's undiagnosed? We know that people that don't sleep well, it means your testosterone is not getting replenished overnight, so you're going to have lower levels of testosterone. What about depression? Is things going on, something going on in your life right now that's making you have that low energy? I check their vitamin B12 levels, their thyroid levels. I ask them about stress, sleep, exercise, diet. All these things can contribute to similar symptoms of low testosterone. You can do a trial of therapy, and if they're not feeling better, you can stop it at 3 to 6 months, or you have them to continue it because we want to prevent against cardiovascular disease and diabetes, and then you just have them see someone else to try to work up other causes that might make them feel low energy or have depression. Well, what about fertility concerns? Again, something you have to ask every person that wants to go into testosterone therapy. And I say this because a lot of physicians or providers have an age discrimination, right? If you're over 40 years old, they think, well, they're done with kids. And we know that that's not true. We know people get remarried. We know people want kids later in life and are having kids later in life. So anyone that is thinking of undergoing testosterone therapy, I always say, are you done with fertility? And if they are, we have 3 options that we can give men for low testosterone that are interested in fertility. That includes Clomid. This is a selective estrogen receptor blocker. What does that mean? It means that in our body, we have testosterone and we have estrogen. And when you have testosterone, it goes into 2 things that your body converts it to, estrogen and DHEA. Estrogen levels help regulate. When your estrogen gets really high, your body says, oh, I must have tons of testosterone because my estrogen's high, so slow down on it. When your estrogen levels are low, the body says, oh, I need more testosterone, let's ramp it up. And it sends that signal to your testicles to make more testosterone. So in a sense, Clomid is just tricking your body. So it blocks estrogen even though you have it in your body, so the body thinks I need more testosterone. It's safe, it ramps up your own natural testosterone, and I have men that are older gentlemen that are on this, that aren't interested in fertility because they prefer the option to take a pill and not have to do any other form of testosterone. But it works great. It is not covered by insurance because it's off-label when it's used for men for low testosterone. It can be anywhere from $12 to $40 a month. HCG, or human chorionic gonadotrophin. This is a chemical that our brain already secretes, but we can prescribe it in a generic form as an injectable medication. You inject 3 times a week, anywhere from 1,000 to 3,000 units, and it stimulates LH, which tells your testicles to make testosterone. It's about $100 to $600 a month, depending on where you get it. It is not cheap, and again, it's also not covered by insurance. And then lastly, we talked about anastrozole as well, aromatase inhibitors yesterday. This is one pill you take roughly once a week. It's anywhere from $12 to $26 a month, and what it does is it blocks testosterone's conversion to estrogen in the body. So it keeps higher levels of testosterone, lower levels of estrogen. Why are these important? How do they work? Well, I kind of talked about it. The SERMs, again, it's showing you just kind of a picture here of the testicle and the brain, think pituitary brain and testicle, and it's showing you where along this negative feedback that they're interacting. But the key here is that all 3 of these work to stimulate your own body's natural testosterone. You're not taking an outside or exogenous source of testosterone. So they're excellent and the only options for young men interested in fertility. They work very well. And I also have patients that are older that are not interested in fertility who prefer to take this. All right, what about cardiac events or stroke? I have patients sent to me that say, my cardiologist said I can't be on testosterone, Dr. Burney. It's going to give me a heart attack or a stroke. And I think, well, where are they getting this data, right? Well, the good news is that we actually just had some recent data that refutes all this. So testosterone therapy, our guidelines say that if you've had a recent cardiovascular event, so within the last 3 to 6 months, if you've had a heart attack or a stroke, you need a whole testosterone therapy for about 3 to 6 months. Now, some of you may or may not have heard about this. This came out just a few months ago. It's called the Traverse study. And this was a study to look at just that. Is it true, does testosterone cause people to have heart attacks? And what they did was they looked at a whole bunch of middle-aged and older men that had low testosterone, and they did it to the highest level of a study that we can do. It's called a multi-center, randomized, double-blind, placebo-controlled trial. All that means is we took a whole bunch of people, half of them got something and didn't know what they got, and the other half got something and didn't know what they got. And then we looked at the data. And we had over 5,000 guys that were between 45 to 80 years old, and some of them got testosterone and some of them didn't, and all of them had pre-existing or high-risk cardiovascular disease. So we didn't take like your average Joe Blow. We took guys that had a history of cardiac disease. They were high risk. So we wanted to see, can we make them, or are they going to have a heart attack or something bad being on testosterone? And guess what it showed? It showed that in men with hypogonadism and pre-existing or high-risk cardiovascular disease, testosterone replacement had no higher incidences of cardiac events than the placebo group. And in fact, the placebo group had slightly higher at 7.3 than the testosterone group at 7. So again, and this came out in one of our famous big journals, New England Journal of Medicine, again, it's been refuted. But yet there's still a lot of education that needs to happen around physicians and providers, and a lot of people get scared. But there's no data showing that it has an increased incidence of cardiovascular disease, but there's a lot of data showing that testosterone levels will prevent cardiovascular disease and stroke. Lastly, another one, polycythemia. What is that? It's just elevated hematocrit levels. Okay, so testosterone is a known stimulant of erythropoiesis. What is erythropoiesis? It's just making red blood cells. Our body needs red blood cells to carry iron and oxygen around in our body. And a rise in your hematocrit is not unusual when you first start testosterone. However, you want to make sure that if they have normal testosterone levels and you see this high hematocrit, you want to make sure you're not missing something else. Common causes of elevated hematocrit or obstructive sleep apnea, again, if you're a smoker, COPD, because your body's trying to make more hematocrit because it's trying to get more oxygen, because you're starving yourself of oxygen if you're a big smoker. So again, when you correct the problem, the hematocrit usually normalizes. So again, testosterone therapy does not in and of itself, if it's at a normal level and it's being regulated, it shouldn't cause an elevation in your hematocrit, but that's why it's important to get your routine labs. Because that's what we're looking for. That magic number is 52. We want that less than 52 to help prevent any elevated risk of blood clot or DVT. If it gets high, you can certainly send your patients to go donate blood or have what's a phlebotomy, which is where they drain blood from you. But that's not a treatment option. It's just a temporizing option, and usually we'll redose the testosterone at that point in time, or I'd look to work you up for some other cause of it, okay? And I told y'all yesterday I would do a last one on PSA or history of prostate cancer. So again, our guidelines say that there's an absence of evidence linking testosterone therapy to developing prostate cancer. We know that patients with testosterone deficiency and a history of prostate cancer should just be informed that there's no evidence to really show a risk-benefit ratio. And that's just because there's only like 6 studies out in the whole literature that talk about this. All right, so what is the data? Where did this come from? What's going on? Well, the available evidence, everything published, shows that testosterone therapy does not increase prostate cancer risk. PSA is an androgen-dependent molecule. That means you need testosterone to make PSA. If your testosterone level is so low, you're not going to make much PSA. And as a result, we have great data from major institutions, major cancer institutions, showing that low testosterone levels in patients actually translate to higher rates of prostate cancer, more advanced prostate cancer tumor grade, stage, and volume. Because again, you're not detecting PSA if your testosterone is that low, okay? So here's one of the studies I mentioned yesterday. This is from UC Irvine. They looked at all these guys that had prostate cancer and underwent a radical prostatectomy. Some of them they gave testosterone to, and some of them they didn't. And they found that testosterone therapy after a radical prostatectomy actually reduced recurrence and delayed the time of recurrence, meaning when the PSA rose again. So this was actually a little bit protective. Only 7% of guys that got testosterone therapy had a recurrence, and 12.6 that didn't get it had a recurrence, okay? Another one, looking again at post-prostatectomy patients, and they actually looked at high-risk guys. Again, these are the ones that we expect to recur at some point maybe, because they're more high risk, meaning positive nodes, positive margins, higher stage, Gleason 8 or above. And they treated them all with transdermal gels, and they found that the biochemical recurrence was only 4% in the testosterone group, and it was 16% in the control group that didn't get testosterone. So again, testosterone therapy does not appear to increase cancer recurrence rates, even in men with high-risk prostate cancer. And then this was a study I did in my fellowship at Memorial Sloan Kettering. We did the same thing. We took over 1,500 men. We gave some of them testosterone, some of them we didn't. And we looked specifically at high-risk prostate cancer. And we showed that in those patients that had high-risk prostate cancer that we gave testosterone to, there were no higher rates of or time to recurrence of prostate cancer. So again, it actually showed almost a protective effect. So really exciting data. The important thing about testosterone is to know what it can and can't do and be realistic about it. Go see a real doctor to get started on it. Learn about all the different options, find out what modality works best for you and your lifestyle. Make sure you understand the risks, that you're going to follow up appropriately, and just know about those special circumstances. Take home is that testicular cancer and its treatments can absolutely negatively impact many things, including fertility, testosterone, and your sexual health. But the good news is that we really do have many treatment options that are available that can help with fertility and can help patients father kids. Banking, EEJs, TESE, all of these options I talked about. Low testosterone is not just an erection or sexual health thing, it is an overall health thing. And it impacts cardiovascular disease, diabetes, and osteoporosis or brittle bones. So every one of you should get your labs checked. You should get your labs checked once a year is my personal recommendation. And tell all your friends because it's important. There are many treatment options available for low testosterone, so go meet with your urologist because your quality of life is paramount because you're going to get over this hump. You're already over this hump. You're going to continue to be over this hump. And now we want to make sure that we're enjoying the rest of these years and we're enjoying that quality and we feel good about it. And these are my little testosterone molecules, my three, that check their balls every month and are really excited about it. So thank you very much for my long